every individual, essentially la columna vertebral is uh, called that because we stacked vertebra essentially. So it's also referred to as la espina dorsal in other countries, and some people call it either la columna vertebral or espina dorsal. So the direct translation of espina dorsal would be the dorsal spine, and la columna vertebral would be the vertebral column. Every vertebra is a bone, so it's a hueso, and vertebra is vertebra, and it's divided into four sections, as we know: the cervical, thoracic, lumbar, and sacrum. We have the cervical, región torácica, región lumbar, y el sacro. And then the sacrum, we know it's five fused vertebrae, so cinco vértebras fusionadas. And we also house within the spine, the spinal cord. So the origin of the word medulla, so we know the renal medulla is the center of the kidney. We know the medulla is in the brainstem, so like the center of the brain essentially. And so the direct translation of a spinal cord in Spanish is the medulla of the spine, so la médula espinal. And the things that branch out of the spinal cord, out of la médula espinal, son las raíces nerviosas espinales, so the spinal roots. And we have this image to outline this. Okay, and we have a little bit more vocabulary. So now we're going to dive into la disreflexia autonómica, so DA, or some people also call it the hiperreflexia autonómica, so autonomic hyperreflexia. And essentially, this has to do with a lot of reflexes that are going on in the body, so reflejos. And we have all of this is due to having a noxious stimuli in the body that the body is receiving and not really identifying. So a noxious stimuli would be estímulo nocivo. And this happens, I'm going to be referring to what happens above the level of the lesion and below the level of the injury. So it's going to be nivel de la lesión. It's going to be above and below. And I'm also going to be referring to sobre or encima being above, and below the level of the injury is going to be debajo. And so we have el sistema nervioso simpático, so the sympathetic nervous system, and we also have the parasympathetic nervous system, sistema nervioso parasimpatético. We have presión arterial, so we really want to focus on blood pressure management when it comes to AD. So presión arterial is blood pressure. And we also have presión alta, which is high blood pressure. We're going to focus on the heart rate as well, ritmo cardíaco, so the cardiac rhythm, heart rate, ritmo cardíaco, and also like bradycardia, so bradycardia. These are just some terminologies in Spanish. Let's see. And so we're going to dive into the pathophysiology of autonomic dysreflexia. So the first thing that happens is the spinal cord injury. So lesión de la médula espinal. Médula espinal, spinal cord injury is lesión. So lesión de la médula espinal. And we have essentially an interrupted communication between the parasympathetic and the sympathetic systems. This autonomic signaling just can't get through. So in return, you get this overstimulation from the sympathetic nervous system. And this mostly leads to an elevated blood pressure. And we have to keep in mind that this is about 20 millimeters of mercury above the patient's baseline blood pressure. So we have to also keep in mind that not everybody's blood pressure is the same. Someone's baseline might be completely different from someone else's. So everything is based on the patient. And so it's important to know their vitals. And this leads to dysreflexia, which is essentially just the entire nervous system going like very unregulated. And then dysreflexia. So what are the causes of dysreflexia? We have, it's typically triggered by a noxious stimulus, so un estímulo nocivo, below the level of injury, debajo del nivel de la lesión, and such as a full bladder and constipation. It is causing, again, symptoms, sudden onset, high blood pressure, about 20 millimeters of mercury above the patient's baseline, and a parasympathetic response that you can only see above the level of the lesion. And we have these images over here. So T6 injury would be right over here. T6 would be right at the xiphoid process, and everything above that would be any of these injuries essentially could experience any AD essentially. And we have Dr. Kirschblum at Rutgers, and he wrote the book of spinal cord injury, and he lists the three most common causes of AD as bladder, bladder, bladder. The fourth one would be bowel. The fifth one is again bladder, and there's also other noxious stimuli, but you always want to check the bladder. Okay, and so the common causes of AD. So we have, again, bladder distension. You always want to check the patient's bladder, whether you want to essentially bladder scan. Yeah, we want to make sure we scan their bladder. We want to make sure that it's not overflowing or too distended. So distensión vesical would be distended bladder distension, and bladder is directly translated to vejiga, and it could also be due to bladder spasms, so espasmos. We could also see other common causes of AD would be constipation, so estreñimiento. It could be skin irritation, such as pressure ulcers or tight clothing. So skin irritation would be irritación de la piel. And pressure ulcers would be úlceras de presión. And tight clothing would be ropa apretada. So clothing is ropa, tight is apretada. And we have other noxious stimuli below the level of the injury would be, we could consider infection, so infecciones. We can consider ingrown toenails, uñas encarnadas. Uñas means nails. And we can consider like venous thrombosis or thrombosis, insect bites, so picados de insecto. So we can tell when it's itching, but you can imagine a patient with spinal cord injury would not be able to tell, and this becomes a noxious stimuli. Or recent or old trauma or trauma. So like an example that I have for like bladder distension or just spasms is we had a patient with Dr. Johnson here. We had a patient who was on oxybutynin essentially to control like her spastic bladder. And she also had an indwelling Foley. So one could imagine that if a bladder has a lot of spasms and the Foley is inside the bladder, it can be causing an internal noxious stimuli to the bladder. So essentially, we were trying to control that. And she also complained about the side effect of oxybutynin, which would be having a dry mouth. She complained about having like really uncomfortable time chewing, especially her crackers. It felt like it was really injuring her mucosa in the mouth. It was making it painful for her to swallow, and therefore she was not eating. Her quality of life was therefore I guess altered because she was unable to chew properly and swallow properly. So we tried to adjust her medication and decrease her oxybutynin dose so that she could feel more comfortable and have more salivary production. But in the end, she started developing these episodes of autonomic dysreflexia, and we didn't really know why until we realized that we had to adjust her medication back to a normal dose. And at this point, we could, there's like another talk about like bladder management, and there are other types of medications that don't have so many adrenergic side effects like mirabegron, but for now, this is something just to keep in mind because it shows that bladder spasms can cause AD. Okay, and so more symptoms, we have high blood pressure is the more dangerous one. It presents as sudden onset, severe increase in blood pressure that can continue rising if not controlled. The patients will complain of a headache, severe pounding headaches, often located in the back of the head. You will see them having sweating above the level of the injury, and it would be just like flushing. So this is a sympathetic response. They would be sweating, there would be flushing, high blood pressure. This is more of a sympathetic response, but you will also see like a parasympathetic response, such as bradycardia and like ritmo cardíaco lento, so like a slow heart rate. You could see again, like presión alta would be high blood pressure. This places the patient at risk for developing like strokes, like intracranial hemorrhages, retinal detachment, seizures, cardiac arrhythmias, or even death. And again, they would be complaining of a headache, dolor de cabeza intenso, an intense headache. And they would also have some parasympathetic symptoms such as nasal congestion, like congestión nasal. And this would be, yeah, the parasympathetic response. They would be sweating, sudor, están sudando. That would be the conjugation. And sympathetic response. This is a sympathetic response because of the noxious stimuli. And we have like enrojecimiento as well. So like enrojecimiento would be flushing of the skin. Skin is piel. Okay, and so this is a picture of what's happening in the parasympathetic and the sympathetic nervous system. And essentially in AD, any of these symptoms would be fair game. So we see sometimes that like people with AD, they do have high blood pressure, and that is the most dangerous symptom of them all here. But we also see in literature that there is not hypo, but bradycardia. However, you do see some patients having tachycardia with AD as well. Um, so this is just a chart that also explains these symptoms. So the most dangerous one would be the sympathetic fight or flight and the increase in blood pressure, and when you have a decrease in heart rate. But really, all of these symptoms can be fair game. You can have increase in breathing rate, dilated pupils, and you can have essentially you can have any of these because dysreflexia just means that nothing is going according to how it should go. But why T6? So we know that dysreflexia, autonomic dysreflexia happens above the level of the injury if the injury is at or above T6. But why? So the most common level of injury in patients who have AD is T6 and above, but there are exceptions. So you do see autonomic dysreflexia in patients who have injuries as low as T8 to T12. But essentially, what's special about this area? Essentially, T6 marks. We can see here like the spinal cord. T6 marks a critical anatomic and physiologic boundary that essentially communicates between the parasympathetic and the sympathetic nervous systems. So to better understand this, we can talk about an intact spinal cord. So when you have, for example, if you're really thirsty in the morning, say you're in the hospital, you're about to round, and you decide to drink an entire bottle of water right before your attending walks in and decides to go on morning rounds. So it's 8 a.m., you're starting to round, and it's already 11:30 and you still haven't peed. So what happens in a normal spinal cord, in an intact spinal cord? Essentially, your body feels that the bladder is full, and it sends like here's a noxious stimuli. It sends information to the spinal cord, and this in turn tells the sympathetic nervous system to send some signals like constrict your blood vessels, and tells the renal medulla to release some catecholamines, and all of that increases your blood pressure, and it goes up to the heart, and the baroreceptors of the heart start to sense this increase in blood pressure, and it tells the parasympathetic area of the spinal cord, hey, like let's regulate this blood pressure. So the parasympathetic nervous system then communicates down the spinal cord through these communication canals that are communication tracks that are going through these levels, especially through T6, and it travels back down to the parasympathetic area that is essentially sending all this information to elevate the blood pressure, and it's telling it to balance it out. So it's regulating the blood pressure. That's why this doesn't happen. We don't see this very often. However, we're also not checking, and we're able to, go to the bathroom on our own. But in a person who has sustained a spinal cord injury, especially above T6, the communication is interrupted. So the anatomical boundary is T6, and this is like the anatomical boundary of the descending inhibitory pathways. So essentially, the parasympathetic information is not getting through, and the sympathetic is just an overdrive, essentially. everything's going to go haywire while the sympathetic is trying to communicate and asking for help, and the parasympathetic is trying to give the help, but there's just no communication. The roads are blocked. Um, and all this leads to dysreflexia. Okay. And so we have diagnostic considerations, things to keep in mind when we're trying to evaluate a patient and determine if they have risks for developing autonomic dysreflexia is we have to do a careful assessment of the patient's medical history. So for example, we have to really know their spinal cord injury level, the timeline of the injury. We have to know prior AD symptoms, like has this person had AD in the past or is this a new thing? We have to keep in mind that, for example, AD doesn't happen immediately after a spinal cord injury. It happens at least 6 weeks after the onset of the injury. So who is more at risk of developing this AD? You have to keep in mind timeline, the SCI level, and other AD symptoms. We have to also keep in mind whether this particular patient has a high propensity for developing UTIs. Are they chronically constipated? We have to make sure we review their bowel care and their bladder regimen, and just make sure that we dot our I's and cross our T's and make sure that everything is well taken care of, and so that we know our patient. For example, I can say, in terms of knowing the patient's spinal cord injury level, there was a patient that I was observing during physical therapy, and I saw that he was standing up, he was walking with some min to mod assistance, and but he couldn't feel his shoes. They had given him new shoes, but he was walking, and he wasn't my patient, but so I didn't know too much about him. But I did realize that he started sweating, and he essentially had to sit down, and we had to remove his shoes and make sure that check his blood pressure, and his blood pressure was 160s, and when you look at his baseline is like 110s systolic. So this is definitely an elevated blood pressure, and he's showing symptoms of diaphoresis and flushing as well. So we want to make sure, what is the stimulus? First of all, I'm like, this man is walking. So I was a little confused, because I'm like, well, it has to be above T6, but he was an incomplete injury. So you can have incomplete injuries. He was a C3 injury, so it could be very high level, but still have incomplete. So you really have to just know their background, because it could be misleading. But yeah, he was undergoing AD, and once we were able to remove his shoes that were causing him a lot of discomfort, his dysreflexia resolved. So yeah, we have to monitor the patient's blood pressure, identify their baseline, and notice any BP trends and orthostatics. Again, people with spinal cord injuries tend to have a baseline low blood pressure. One time I went into the gym, and a patient was being put on a tilt bed, and essentially they were being sat up, and they were working on standing them up, but their blood pressure while doing that, it dropped very low. So you have to keep in mind that patients with spinal cord injuries tend to respond a lot to orthostatic, to be very orthostatic, and so you have to use this. But you can also use the orthostatic changes to your advantage when managing AD. So the first thing that you want to do when you manage AD is elevate the head of the bed and allow the gravity to essentially promote venous drainage from the brain. The first thing you want to do is decrease their blood pressure. So you want to elevate the head of the bed and try to identify the trigger. So immediately assess the patient and address the underlying cause, such as a full bladder or fecal impaction. You can speak to the team and ask when was the last time the patient received bowel care. You can ask the patient when's the last time they received bowel care. They'll be able to tell you. Sometimes they may have a Foley, or you might know that they're intermittently catheterized, so you want to know when. You want to make sure that there's not any plugging if they do have a Foley. So a bladder scan would be very helpful. And you also want to maybe see if they have been constipated. Maybe you'll have to do some digital stimulation, or disimpaction. If you want to make sure that they have, if they haven't had a bowel movement in a long time, you want to make sure that they do, because that could be a trigger. You want to make sure you check their wounds again. So an example would be If someone has a sacrodecubitus ulcer and they're just sitting on it, one, check that the pressure is off the wound. Two, check for possible infections. Make sure that it's not actually infected, and then proceed to take steps to aid that situation. But also make sure that you check even the packing of the wound. Sometimes packing of the wound could be a little tight, and that could be causing a lot of pressure that then triggers AD. And so the next step after identifying the trigger, and this is not just in consecutive order, this is all happening sort of at once. You're trying to identify and eliminate the trigger while at the same time you're taking their blood pressure and making sure that it doesn't keep going up. And you want to administer medications if necessary. So you want to administer medications not as a treatment, but in order to buy you time. So you want to be able to decrease the blood pressure because you don't want these bad things to happen, like a stroke or retinal detachment or cardiac arrhythmias, strokes, and even seizures and even death. So we want to administer these medications to give you time. And if all else fails, if you are in a standalone facility, you would consider hospital admission, transferring them out if that's if things are not within your control with the resources that you have. And so some pharmacological interventions that we can use are like topical antihypertensives. That would be the first thing to do. Nitroglycerin paste is something that you can use. You can apply 1 to 2 inches. Typically, this is done above the level of injury, and it's a vasodilator, so it will decrease their blood pressure, but you have to continue monitoring their blood pressure every 2 to 5 minutes because it will continue to drop if you just leave it on the skin. And you have to remember to remove it once the blood pressure has actually reached the goal that you want. You don't want it to continue dropping. But at the same time, again, like placing it above the level of injury, that opens up a lot of options for where you could place a nitropase if they have a lower injury. So if they have a T6 injury, that's the xiphoid process. Essentially, you could put the paste like on the chest or on the forehead, but you have to remember that you placed it there. So you have to remember to remove it. And if you place it on the chest, you can easily forget. So one of the just go-to areas would be just the forehead. You can put 1 inch, and if that's not working, try to put 2 inches. I've put 3 inches and continue to monitor. I've never actually had to use any oral antihypertensives on patients. And I would feel a little bit more conservative about doing this because you want to make sure that you're able to monitor and to control the drop in blood pressure. So once you give a patient an oral medication, you don't know how sudden the effect is going to be or how drastic the effect is going to be in terms of decreasing the blood pressure. So an option would be like nifedipine. You can bite and swallow and as an immediate release, but try not to give sublingual nifedipine because the absorption is unpredictable. And another thing you can give is sublingual clonidine. It can be given hourly if there is no change, and you want to continue monitoring their blood pressure. You want to monitor their blood pressure continuously again. And other possibilities, you can consider the risk of the possibility of an infection. So you can obtain blood cultures, respiratory swab, get imaging like a portable chest X-ray, consider starting a patient on broad spectrum antibiotics if you suspect an infection, and consider other causes like something that the patient would not be able to tell you and that you would not be able to see on the surface would be like appendicitis or renal stones and like cholelithiasis. And in that case, you would want to consider transferring them out to an acute care hospital. Okay, and so long-term prevention and treatment of AD. So one thing that we can do is prevent AD by giving patients and their families some resources to make sure that we try to avoid this as much as possible. It's very dangerous. We want to make sure we have the patients on regular bowel and bladder regimens. So we want to make sure that they're that they're consistently getting scheduled medications that allow them to have daily bowel movements. That way they don't get too constipated. And same thing with the bladder. We want to really understand the patient. So the way we prevent this while we're inpatient is we usually measure the intake and output in patients. So for new admissions, we make sure that the patients get post-void residual volumes. And then if the patient, say, urinates like 300 milliliters, we still want to bladder scan them because we don't know the type of bladder that they could have. If we don't know the patient, they might have like they could have an overactive bladder. Sometimes this can lead to like overflow incontinence, so they could still be retaining. If like this, it could be misleading that they're still urinating because they could still be retaining depending on whether they have this type of bladder. We want to make sure that the amount of the bladder is less than 350 cc's when we do bladder scan, and if it's greater than 350 cc's, we can catheterize them. Some patients might benefit from having an indwelling Foley or a suprapubic catheter, depending on the injury that they have and depending on their needs. And again, we use 350 cc's, but I know that some attendings prefer to give the patient a little bit more room, either 400 cc's. Some people are more conservative and they say like 300 cc's. And so we also want to encourage patients to have regular exercise, and this is done with physical therapy, occupational therapy. That's how we manage this while inpatient. But upon discharge, the physical therapist and occupational therapist will give the patient a home exercise program, and they will also meet with patients' families and do family training before the patient's discharged home. And this can improve the patient's cardiovascular health and reduce their risk for AD. And lastly, we want to, again, educate and raise awareness about this. We want to educate the patients and their families about like comprehensive education and resources that we can give them to empower them to not necessarily manage, but sort of be able to identify that AD is happening, and so that they could find the resources that they need to help their loved ones, because we don't expect families to manage it. But if we do give them the resources to identify it, then we can prevent a lot of detrimental things that come from AD. Okay, and then so what do? We inquire, we explain, and we reassure. So the first thing we want to do when we see a patient is inquire about the symptoms. If we think that they're undergoing AD, we can ask them how they're feeling. Like, do you have a headache? ¿Tiene dolor de cabeza? Are you feeling warm? ¿Tiene calor? Like, do you feel like you're sweaty, like sweating? ¿Siente que está sudando? And then we can, this could be like while you're managing AD, it could be a little bit stressful for you too. So we don't expect you to remember like a lot of jargon or a lot of vocabulary, but you can go with quick things like, have you peed? You could say, ¿ha hecho pipí? ¿Cuándo fue la última vez que tuvo un movimiento intestinal? When's the last time you had a bowel movement? Or you can just directly ask them, ¿cuándo fue la última vez que hizo popó? O ¿cuándo fue la última vez que hizo el número dos? And those are globally understood as when's the last time you pooped and when's the last time you did number two. Like, people will understand, and this is an acute scenario, so you want to just use that if you don't have an interpreter at your disposal. Let's see, so then you want to explain the plan of action. So you want to tell them what's going on. Tiene presión muy alta, so your blood pressure is very high. Tiene la presión muy alta. I'm going to sit you up, so lo voy a sentar, voy a sentarlo, o voy a sentarla if it's female. And we need to check your bladder. Necesitamos revisar su vejiga. And we need to do digital stimulation. Necesitamos hacerle estimulación digital del recto. And we need to give you some medication. Vamos a darle medicación. We're going to give you medication. And we can also provide reassurance. So like, está en buenas manos, you're in good hands, and we're going to help you. Le vamos a ayudar. La vamos a ayudar if it's a female patient. Lo vamos a ayudar if it's a male patient. And so now we're going to start with some interactive sessions. So I encourage anyone to participate, to unmute yourselves. First, we're going to start with some cases, and we're going to practice the sentences in Spanish. So the first cases, they're going to be in English. So I really just expect, it's really just to help everyone really hone in the details of identifying and managing AD. And then we're going to jump into more things in Spanish. Okay. So the first thing we have is a case discussion. So a 46-year-old male with a C3 incomplete spinal cord injury is noted to have flushing, diaphoresis, and a blood pressure of 155 over 80 during therapy. What questions would you ask this patient and which actions would you take? Feel free to unmute yourselves.
Asking if they've had any headache at all or
Mm-hmm.
any other symptoms that they're feeling.
Mm-hmm. Good. Yeah, so you want to ask them essentially how they're feeling, if this is out of the norm for them. You want to ask them when's the last time you had bowel care? Have you had bowel care today? Do you feel like anything specifically bothering you? Sometimes you just have to assess them. And let's see. So an example that I have is one time I walked into a patient's room. Well, one time I received a call from nursing saying, "Hey, like I didn't mean to call you, but the patient really insisted that I called you. His blood pressure is 130 over 80, and I didn't think that was too alarming, but he really insisted that I call you." And when I heard that, I was like, "Yes, of course, I'll be right there," because his blood pressure was baseline 90s. So this is definitely the onset of AD, and we just want to prevent it from going up even more. And the noxious stimuli for him at that point was that he didn't realize it, but he was actually sitting on his hand. So we removed his hand, and we also noticed that the little bracelets that the hospital gives him were also kinking into his skin. So we want to eliminate any obvious noxious stimuli and ask them some questions about to figure out what could be bothering them. So okay. In another case, we have, so it's time for morning rounds. You evaluate a 68-year-old female with a T5 injury at bedside and notice morning vitals are being taken. Her blood pressure is 140 over 85, but you notice that her baseline BP is typically 90s to 100s. She has a Foley catheter. So a Foley would be una sonda, catheter. So it would be the same thing. You could use them interchangeably, catheter or sonda, with good urinary output. And yesterday's UA was negative for UTI. UTI would be infección de las vías urinarias. So what would you do? What would be the first thing you would want to do?
So I think in this case, we'd maybe want to sit her up, remove any tight clothing, check her skin, ask her a couple more questions about maybe when was the last time she had a bowel movement or things like that.
Perfect, wonderful, thank you. Yeah, so a lot of this is repetitive, and it's essentially just to bring awareness about what's happening. But yes, perfect. So now we're just gonna match the words. All right, so the first one would be spine. And this is the word pool, so can I get some volunteers?
The columna vertebra.
Perfect.
Okay.
All right, the next one would be spinal cord injury.
Lesión de la médula espinal.
Perfect. And then we have autonomic dysreflexia. It's the pronunciation.
Dysreflexia autonómica.
Beautiful. And then we have high blood pressure.
Presión alta.
And we have a Foley.
Sonda.
And we have bowel regimen.
Régimen intestinal.
And the last one is urinary retention.
Retención urinaria.
Perfect. All right, so yes, so spine, la columna vertebral, spinal cord injury, lesión de la médula espinal, autonomic dysreflexia, dysreflexia autonómica, high blood pressure, presión alta, Foley, sonda, bowel regimen, régimen intestinal, and urinary retention, retención urinaria. All right. And we're going to fill in the blanks here. So the only thing that will lower the BP is removing the
Noxious stimuli.
beautiful. And it's not going to fill in the blanks. We're just going to see that in the next one. So we're going to move on to this box. So it's the same thing, but in Spanish. So la única cosa que va a bajar la presión alta es remover el
Estímulo.
estímulo nocivo. Perfect.
Nocivo.
Good, good. And so we have this one over here. So blank blood pressure in AD is caused by a possible PNS/SNS response at this location.
High blood pressure in AD is caused by a sympathetic response above T6.
Beautiful. Okay, good job. And then the same thing, but in Spanish. So la presión en la DA es causada por una respuesta por. It's more of a direct translation of this one right here. So we said this was high blood pressure, so la presión
Alta.
en la DA es causada por una respuesta. We said this was
Simpatético.
It's actually simpático. I also would
Simpático.
say, yeah, I would also say simpatético, but no, it's simpático. Por
Estímulo.
Tesis.
So por encima del nivel de la lesión. That's what I would say, but either is correct. And then here we have the most common cause of AD is which organ?
Bladder.
Perfect. And in Spanish, la causa más común de la DA es
Vejiga.
good. Perfect. So you guys did great. So the only thing that will lower the blood pressure is removing the noxious stimulus. So this would be la única cosa que va a bajar la presión alta es remover el estímulo nocivo. And then we have high blood pressure in AD is caused by a parasympathetic response above the level of the injury, which would be the same thing as la presión alta en la DA es causada por una respuesta parasimpática por encima del nivel de la lesión. So yes, at or above T6. And the most common cause of AD is bladder. And la causa más común de la DA es la vejiga. So perfect. And I think I finished a little bit early, but these are my sources, but I can go back and answer any questions if anybody has them.
I had a quick question.
Thank you.
Just about,
Go ahead.
oh, sorry. Just about like the timing, like how long these symptoms last. Does it last until you actually get rid of the stimulus, or
Yeah.
it's kind of ebb and flow?
Yeah, so they will definitely last until you find the stimulus and remove it. So if it's a very obvious stimulus, like the patient that I described, that he was sitting on his hand and things were kinking at his skin, then yes, that could be that could last just a few minutes. But this same patient had AD run for about 3 hours, and we had to continuously we had already done digital stimulation. We made sure his bowels were empty, his bladder was empty. We didn't really know what was happening. So in that case, he was one of the people who needed blood cultures, and we later found out that he had bacteremia. We had to send him out. So until like we started him on broad spectrum antibiotics, but he had just recently had a surgical procedure, so it was a complicated thing, and at that point he needed to be on just like blood pressure management, and also in under acute care in an acute care hospital to continue to find that noxious stimuli / treat the infection.
Gotcha. Thanks, Ivani.
Thanks.
So Ivani, great job. Thank you so much. I think you mentioned it earlier, but so could AD be happening both in complete and incomplete injuries kind of at the same rate, or is it more common in one than the other?
I'm not entirely sure about whether it's more common, but yes, it can happen in both. So I mean, I'm assuming I'm gonna. Oh, go ahead.
Hi, it's Taylor. I'm one of the SCI fellows at Kessler. Great job, Ivani. As Ivani mentioned, we rotated together on an SCI service earlier this year. She did strong work, and we had lots of educational cases that month. But anyway, yes, I was actually going to comment on one of the slides where you mentioned the level. I think you mentioned T6. AD is more common in complete injuries, and it's more common in tetraplegia than it is in paraplegia. So if you're thinking about tetraplegia, it's like cervical injuries, higher level injuries. Thoracic level injuries can sometimes, I mean, is it really paraplegia? It's debated, but higher levels, so like C4, C6, those are going to definitely affect the arms and the legs, and those patients are going to be at increased risk for autonomic dysreflexia. To answer your question, I think the one slide said that T6 was the most common level. I think that is a little misleading. AD primarily occurs above the level of T6, but the most common levels are still the cervical level injuries. Those patients are going to be at the highest risk. And complete, probably like 80 to 90% more likely than incomplete.
Thank you, Dr. Johnson.
Thank you.
Yeah, you're welcome. Good job.
Any other questions?
I had a question as well. Hi, Ivani.
Hello.
Hi, it's good to see your face. So I was wondering about the tipping point, I guess, moving between like a paste, a nitroglycerin paste, to an oral med. At what point, I guess, do you go ahead and consider moving on to that next step? You know, should all of the other kinds of things not be working, removing the stimulus and, you know, setting the patient up and all of that?
Yeah, so the way I've seen it is with management, you start with like 1 inch of nitro paste, and then if this doesn't help, my attending was like, try 2 inches, try 3 inches, and see if that's helping. And if that doesn't cut it, and you've already been trying to, you know, either do digital stimulation, you've checked the bladder, you've checked all the noxious stimuli, the patient's very thoroughly assessed, then that's when you want to either move on to oral antihypertensives. But again, this patient was responding, like the case that I'm thinking about, the patient was initially responding well to nitropase, but then just as soon as this was controlled, like a few minutes later, the AD kicked in again. So I'm assuming it's different for every patient. I don't know if Dr. Johnson, you also have something to add to this as well, but I would think that once you've exhausted the 1 to 2 or even 3 inches of nitroglycerin paste, and if that's not working, then I would move to oral antihypertensives.
Yeah, I think that's a pretty good method. You want to check quick things quickly. So bladder is usually your number one. So you want to make sure the bladder's empty. If that's already ruled out and you want to move on to checking other things, then consider putting the nitro paste on before you go and check the bowel. Because if you do need to disimpact the patient or do a suppository or digital stim, that's going to incite actually AD itself. So the patient's blood pressure may get even higher when you go to check in the bowels. So I would say check the bladder first, number one thing you're going to do. And then if you're going to go to, you know, exposing the patient, checking the bowels, then add the paste because you expect the blood pressure to rise. And then another thing that they say is that depending on the level of the blood pressure, so if the systolic, I should say, blood pressure is higher than 150, for example, then some resources will say to give something oral or to give the nitro-paste right away before you even investigate further. And then, as Ivani touched on, if it's something that you think is going to be long-standing, like this patient had bacteremia or they have a UTI, that's not something that we're going to easily fix. So then you can consider giving an oral antihypertensive agent that's going to last a little bit longer, because obviously nitroglycerin is short-acting. That's going to leave the system, and then they're just going to go right back up.
Mm-hmm. Yeah, and thank you, Taylor. And so for another thing that can also help that I didn't mention is when you do insert the Foley, if you're trying to manage the ED and do the digital stimulation, one thing you can also use is lidocaine jelly. That way the patient can that way it's not as bad of a stimulus for them as well.
Thank you guys. And thanks for this presentation. It's so necessary and important. Really appreciate it. Thank you.
Thank you. And any other questions? We can also do immediate translations if there's anything else that you think you would want to ask a patient. We can directly translate to Spanish, or otherwise just, whatever you guys would like to do at this time. And if not, thank you so much.
Yeah. Thank you so much, Ivani. If anyone else has any other questions, definitely shoot them out now. But if not, thank you everyone for coming tonight. This was great. Ivani, thank you so much for putting this together for us. It's very helpful. So yeah, thank you guys very much, and have a good night.
Thank you so much. It was a pleasure being here, and yes, I'm excited to continue learning about this myself, and encourage everyone to do well. Yeah, thank you so much.
Thank you. Thanks, Ivani. Appreciate you.
Thank you. Hi, Lucila.
Bye.
Thank you.
Thank you.
That was amazing. It was great. I think they loved it.
Oh, it's very kind.
It was very, very comprehensive.
Good. And if you guys have any questions, feel free to reach out as well. And yeah, I'm very glad. And thank you so much for having me.
Thanks so much for coming back. And Newark looks really nice in your background.
That's what I was gonna say, right? This is definitely Newark. Alrighty. Okay, so I'll stop the share, and all right, and now we're hanging out. All right, well, thank you guys. Have a good night.
All right. Good night, everybody.
Good night, guys.